Welcome to the Turd Nerds. We are the functional gastroenterology podcast discussing all things poop. Before we take the plunge into today's episode, let us tell you a bit about ourselves. I'm Dr. Rebecca Sand, a naturopathic physician and acupuncturist, and I specialize in all things gastroenterology, hormones, and fertility.
I'm Dr. Ami Kapadia, and I'm a medical doctor trained in family medicine and functional medicine with a special interest in gastrointestinal health, food and environmental allergies, and autoimmune disease.
And I'm Dr. Ilana Gurvich, a naturopathic physician and acupuncturist who is board certified in naturopathic gastroenterology. I specialize in inflammatory bowel disease, IBS, and other functional digestive disorders. Let's jump into today's episode.
The following discussion is for educational purposes only and not intended to diagnose or treat any diseases or conditions. Please consult your doctor before incorporating any of this information into your care. The information presented on this podcast is not medical advice.
Okay, everyone, welcome back. Dr. Kapadia is presenting today on IBS and atopic disease. And she's already blown my mind with this title because I would have thought we were going to talk about SIFO again, but we're not. So
I do other things, Rebecca.
Amazing. What? I'm so impressed.
I'm broadening my horizons. Now, so first I want to ask you, what do you think of with atopic disease? Like, do you have any idea what I'm talking about, right?
What's dermatitis?
Postnasal drip.
You got almost all. So we generally think about atopic dermatitis, allergic rhinitis, asthma, kind of all in the subset of atopic diseases, right? Rashes, yep. In general. So what we're going to talk about is, it seems like a lot of patients with digestive issues overlap with having atopic issues as well and vice versa. And so I wanted to sort of introduce this topic that I've been reading more about in some of the articles I read. They're calling it atopic bowel, where there's this sort of like irritation of the gut from allergens as well, whether it's inhalant or food sensitivities. And so I know we just started talking about food sensitivities, but not a lot of people think about this potential overlap between inhalant allergens and gut symptoms, right?
Totally.
Yeah.
Because we think about breathing inhalant allergens, but we also swallow them.
Right.
So you can have this overlap. And so I wanted to talk about potential correlations with these two very common subsets of symptoms that we see in people. And so the first study I wanted to talk about, it was looking more at the role of food sensitivities in GI disorders. So in general, again, we're looking at and correlating to atopic disease. So they looked at 71 patients, similar, our last study was 70 patients. So 71 patients, 66 of them had IBS, 43 had some sort of atopic disease. And of those 43 with atopic disease, all of them were sensitized to inhalant allergies, right? So you know what I'm talking about when I say inhalant allergies.
Mm-hmm.
Okay.
Environmental.
Right.
Give us a definition. Just in case
so
we
pollen, dust mite, grass, mold, all of the things you can inhale, pets, cockroach is in the mix. But so yeah, you can become sensitized to a lot of inhalants. And so again, of all the atopic patients, all of them were sensitized to inhalants, and a significant number of them were also sensitized to food allergens. And so in this study, looking at this group of patients with sort of a mix of IBS, atopic disease, or both, they looked at skin prick tests, they looked at blood testing of antigens, and symptom picture. They looked at a couple lab markers as well. And specifically, they looked at tryptase, which is an enzyme in mast cells. They looked at eosinophils, and they looked at IgE in duodenal biopsies. And so what they found overall was that in the atopic patients, they had higher numbers of IgE positive cells in duodenal mucosa. So what we're saying here is that these atopic patients had inhalant allergies, right? Mm-hmm. Some of them had food allergies, not all of them, but all of them had inhalant allergies. And of that group, they in general had more IgE positive cells in their duodenal mucosa. So this potential link between like inhalant allergens and inflammation in the gut.
People who have allergies, sinus or whatever,
right,
we're finding evidence of those allergies in the gut.
Right.
With IgE on biopsy.
With IgE positive cells on duodenal mucosal biopsies.
Is it just me, or are we just finding a bunch more eosinophilia in patients?
It seems like it. It seems like just with the whole allergic phenomenon, we're seeing more
everywhere.
Yeah.
In the rectum, in the duodenum for these
We did
people.
talk about, yes, in the last study
I mean,
as well.
I will tell you that maybe it comes down to the fact that I'm admitting it exists.
Right.
But I am seeing more atopy everywhere in my GI population.
Right. So that's probably playing a role in a subset of them in their gut symptoms. So in addition to finding IgE positive cells more frequently in these atopic patients, they also found higher intestinal permeability. So again,
How did they monitor it? Did you know?
That's a good question. I have to look back to see if they did the lactulose mannitol or if they did a different assessment, but we can put the reference to the study. They also found patients with GI symptoms that they attributed to food sensitivity in general had higher prevalences of IBS, of course, I mean, that makes sense, and higher prevalence of atopic disease. So in patients that thought they had food sensitivity, a good number of them had IBS and a good number of them also had atopic disease. So there's this, correlation between...
Did they separate between constipation, diarrhea?
You guys are asking way too many questions.
You didn't
You'll have to read the article.
Entire paper?
I don't think they did, because it wasn't a focus just on IBS. It was kind of like looking at this relationship between inhalant allergens, atopy, and gut symptoms, not specifically like particular types of IBS.
Yeah.
So overall, there was this elevated number of IgE cells in the duodenum, increased intestinal permeability in atopic individuals. And overall, they found this sort of like connection between atopic disease and GI symptoms in a subset of patients, which they were calling this atopic bowel sort of issue.
I mean, I'm just like sitting here and thinking about how many patients that I have that are atopic that I work up for SIBO, work up for SIFO, work up for, large bowel, work up. And I'm like, oh, it's probably like an intestinal IgE.
It could be to allergens. And then it's like, is it inhalant or food? And so I do refer a lot to a wonderful allergist in town because I just find so many of these patients have inhalant allergens that I think are affecting their gut, whether it's, we don't know all the mechanisms. Is it because of intestinal permeability? Is it because of inhalation of allergens? There can be cross-reactivity with dust mites in certain food products. Like,
I do
there's
think
this
I'm
correlation.
missing a chunk.
Yeah. And so we'll talk about testing. You can start with a blood IgE inhalant panel, which I often do for our region, before sending them off to the allergist just to get some data. And in about 50% of people, that's been helpful. In this study, they found that those who had self-reported food sensitivities linked to their atopy or GI symptoms. So guess the 3 most common self-reported food sensitivities.
Gluten, dairy, and egg.
Yep.
Yay!
So those are the most common ones. They said wheat, but I mean, at this point, we usually do gluten. And hen's egg, they did specify. So I don't know if duck egg would be different or, So kind of
Have you guys ever seen a duck egg?
I've eaten duck eggs.
They're huge.
They're huge.
They are huge.
They're massive.
They taste really good, too, usually.
I feel like I just get so grossed out because they're so big.
I mean, they are big, but...
And you probably need one duck egg.
I don't eat them regularly enough to monitor.
Have you guys ever seen an ostrich egg?
No, and I don't think
they're
I
like
would
the size
eat
of your
one.
head.
Would not want to eat one.
An ostrich egg is the
She draws
size
the line
of
at
your
ostrich.
head.
All right, moving on. So overall conclusions from this study: the prevalence of IBS-like symptoms is increased in patients with atopic disease compared to non-atopic patients. So again, this potential relationship between allergens, whether they're inhalant or food, digestive symptoms, and atopic disease. And adult patients with IBS who also have atopic disease may have increased intestinal permeability compared to IBS patients without atopic disease. So that's kind of like, okay, is it a subset of, is your patient sort of in this subset where they have IBS and atopy or not? Because not everyone with IBS has food and environmental allergies, right? So it's kind of a subset.
Okay, are we testing? Are we working these people up? Are we, like, they come in with a GI presentation and then we immediately jump to a blood allergen panel?
Okay, so...
Or why not just give them antihistamines?
Does antihistamines make a difference?
Well, I prefer to identify if I think they have atopic disease, and usually we can tell from our history, right? So if they have a history of seasonal allergy, if they have allergic shiners, usually we can see that. If they have symptoms that flare certain times of the year with any of their respiratory... Sometimes I've had patients that get gut symptoms more, like during certain seasons.
Totally.
And so
because of this underlying
inhalant,
bug.
I think so.
Yeah, mold illness though, yeast.
I don't like to talk about that anymore. But yes.
That's interesting because you spent years only
I did
talking
not.
about that.
I deny. It's been removed from the
Okay,
internet.
it doesn't exist.
Because you literally have a class.
Please,
only
okay,
about mold
it's
illness.
been taken off my website. Yes.
For the
bummer.
purposes of this episode,
We are only focusing on gut fungus at this point. So, yes, if you've had environmental allergy, that also can contribute to some of the gut symptoms. So we're talking about we'll talk about the workup here in a moment. So this overall association that we talked about, and so how can we diagnose it? So in this particular study, they found they couldn't always document it based on skin prick or IgE tests, particularly for foods. I think for inhalants, it's more accurate. So I'll give you my go-to for food and inhalant testing. So why don't we talk about that now, actually? So basically, I think as we talked about in our last episode, elimination challenge really is the gold standard for food sensitivity. There's no other great way. We can do IgG testing. Allergists can do skin testing, but even they've told me, it really depends on your clinical response. This is not...
How do you avoid allergens?
Right. No, I'm talking
allergens.
about food.
Okay.
So for food, my go-to is if they'll do it as an elimination challenge. Mm-hmm. Sometimes IgG food testing, knowing it's a very imperfect test. For inhalant allergens, I like to order, I think for us, it's called a Region 17 IgE inhalant panel through Quest, LabCorp, or any of our big systems.
Wait, say that one more time.
I believe we're Region 17. You'll have to check. But There's an IgE inhalant panel for each region of the country that will test all of the inhalant allergens for that region. Through
How
blood.
is that different from skin prick testing?
Okay, so the IgE, what my findings have been, it's been helpful in about half of my patients, meaning I think they have allergies and I'll get some hits of positives. The problem has been there seems to be a subset of patients that don't make enough IgE antibody. So their total IgE will be 7.
Oh, wow.
And so then you're not going to get any hits on that. And it doesn't rule out inhalant allergens. It just means we cannot use this test.
Right.
I've sent people to an out-of-town allergist because this patient was driving down from Washington. And they said, don't worry about this low IgE. There's, from all the research I could find, it can be linked to some recurrent respiratory URI illnesses,
Whoa.
but there was no pathologic condition they could link it to or follow up that they told my patient they needed. So for me, it's been, if I either find positives, great, we have some information. If I don't, and I still suspect allergies, I often will refer them to the allergist because skin prick testing is more accurate. Neither one is perfect, but skin prick testing, I think, is more accurate. It picks up more.
It's more sensitive.
Mm-hmm. I think it's more sensitive than blood testing. And both of them can have false positives, because you have to clinically correlate. And I was going to say something else that I totally forget about blood testing. It'll come to me, and skin testing.
Should we just spout off keywords? IgG...
It wasn't IgG, it was IgE, and it's not coming to me. Anyway, it'll come back. But so there's this issue with not making enough IgE to make that test accurate. But it has been helpful in sort of figuring out if this could be a piece of their gut or atopy, which in atopy it often is, and gut it frequently is.
So I'm just going back to way back when in season 1, when we did our celiac episode, and we were talking about how total IgA was our foundation marker to see if the rest of the test was our control, right?
Right,
is that the same here? Total IgE is in those panels, and that's
I remembered
the
what I was
control.
going to say.
Okay, you go.
Okay, so if someone has had allergy shots, they will not have an accurate IgE inhalant panel. So if they had allergy shots... I asked an allergist who was very senior, and I said, my patient, I'm coming up with nothing, and I know she's got serious allergies. And I said, she had allergy shots as a kid. And he's like, yeah, you can't. That's why you always want to get their first IgE inhalant panel they ever had done, blood test, before they ever had allergy shots. Oh. And I don't know I can't explain the full mechanism of that.
Do you understand how allergy shots work?
Allergy shots, we can talk about that, and I do think it's a very good therapy as far as what can we offer patients that can actually fix the underlying immune dysfunction. In conventional medicine, it's one of my favorite things. I wish I could do them, but I'm not an allergist.
And so what I'm hearing from you is even if we have this population of atopic gastritis, basically,
right.
one of our treatment options should be allergy shots.
Allergy workup and discussion of allergy shots. It's a big commitment. There's a few of us that do sublingual immunotherapy, which has pros and cons. It's under the tongue. And so there's different opinions on that. I think allergy shots are a great tool. So I do frequently refer to our allergist. I think not everyone wants to do it. You have to go frequently. It's 3 to 5 years of shots.
Yeah, it's a huge commitment. Do you think an allergist would be on board to do that if the only symptoms were IBS?
The one I use is.
Yeah, noted.
I think I found allergists to actually be I found a few great allergists that are open to working with
Maybe
patients
send them
with
this paper.
diffuse symptoms. And I think they often have some respiratory something. Mm-hmm. And so, I think it probably does help, at least for insurance purposes, if you've got something, even part of the year you've got nasal congestion, et cetera, because I don't know that it's approved just for, the research is not on IBS and allergy shots. The research is on respiratory symptoms.
If you have a definitive test, though.
Like if you have they have GI-based symptoms and also respiratory symptoms,
I think you need, right. With certain atopic issues, if they have asthma as well, definitely, I think there's a potential for it. And allergic vaginitis, there's also potentially.
Oh, allergic vaginitis.
I just referred a few patients specifically, and they did have quite a few inhalant allergens. There's a published paper on resolution of chronic vaginitis, which could be diagnosed as yeast vaginitis, but it's the allergies that keep triggering the inflammation. So if you have patients with that, it may be also worth an allergy workup, whether you start with an IgE inhalant panel, which I often do. I mean, it's a whole nother topic, but for chronic vaginitis, we definitely want to do all of the infection workup, right? Yeah. With vaginal swabs. But I do frequently, if it's become a recurrent issue, I often find food sensitivities or inhalant allergens to be part of it.
That is super interesting.
Yeah, and you can do intravaginal cromolyn.
Oh, wow.
As a trial, yeah, which is pretty interesting.
That is really interesting.
They can make it compounded, or you can use the vials and have them apply it topically just to see, does this help,
Mm-hmm. Wow, that is really interesting, actually.
Yeah, so... Wow. The latest. It's not the latest. I read it 20 years ago in a blog.
This is what
when I was researching a patient.
I will say that chronic vaginitis is a huge complaint in a subset of our patients.
It does seem to be.
That is it is
no one knows what to do.
And it's so destructive. Mm-hmm. But I'm thinking, whenever we do these recordings, I'm always like, oh, bing, that patient.
Right.
I need to think about this for that patient.
So there's a great allergist. I remember when I was putting together a presentation on allergic stuff and I forget what else, Dr. Croker, and he had a series, I think it was a publication or an article he wrote on this sort of allergic vaginitis phenomenon. I think he's retired now, but he was one of the pioneers for sublingual immunotherapy, and I believe that's what he used frequently to help desensitize these patients. So if you have patients with chronic vaginitis that's not responding to typical interventions, no one knows what to do, or it keeps coming up as yeast, they could have allergy to Candida foods and inhalants. Right. And treating them for all of them could be really life-changing.
So just out of curiosity, let's say we run a blood test on this, like an allergy panel for these patients, but we also run a Candida, IgG, IgM, and IgA.
Right.
If we find IgE, IgA, or IgG elevated, we should think about the systemic interventions, like the cromolyn, like the ketotifen.
The IgE I only do if we're thinking about. So I don't typically do IgE Candida. I can't remember it ever coming back positive. That being said, there are a couple studies where they did skin prick testing and it was positive. So with Candida, I typically do the IgA, IgG, IgM.
And then if those come up positive, what's your thinking?
Then I tell the patient that there may be a problem with how their body interacts with yeast. And I can't tell them if it's an overgrowth or an allergy or both, but let's try treating the overgrowth if they have symptoms, see if they get any better. If they don't, and or they seem to respond to therapy, but it keeps coming back, or they have allergic vaginitis, I do often send them to an allergist to get them tested for molds, yeast, inhalants, know? So it can be super helpful for patients that they're super frustrated, understandably.
Because I have a patient right now who has a positive Candida immune complex, through Quest, who also has a positive, I think she had positive IgA, IgM, and IgG for Candida. Yeah. And she's a type 1 diabetic. Oh. And, her blood sugars are controlled.
They are?
I mean, for a diabetic. She's got really good blood pressures for insulin-dependent diabetic.
Okay. I'll let you finish.
Well, no, I'm just thinking, do I send her to the allergist?
I think it would be worth a shot, but for her, I suspect she has overgrowth, because I did just test a type 1 diabetes patient that I prefer to say a patient with type 1 diabetes who is super well controlled, and all of her Candida testing was totally negative.
So
I don't think it's an automatic if you have diabetes, because we know blood sugars are not going to be perfect.
So I did put her on my Candida protocol, my fungal protocol, using pharmaceuticals and using herbs.
And off of sugar?
And off of sugar. I mean, her blood sugar was pretty well controlled. Okay. So she felt worse.
Okay.
So then, like, that's why I'm thinking, okay, well, I assumed it was an overgrowth because the immune complex
It could be, and she could be having, like, quote-unquote die-off, which I don't love the term, but so she could be allergic to Candida, which will make her feel more die-off symptoms than someone who's, not everyone who has a fungal overgrowth is also allergic to yeast and molds. Right. So they won't feel as bad when we're killing this off. But if you think about it, like, if you're treating SIBO and someone's allergic to the bacteria and we're killing things up, it's a double sort of whammy of feeling bad.
With this particular patient, I should, next time I see her, find out if she has some atopic
I would
symptoms.
do a general allergic history. Yeah. Sinusitis, allergic rhinitis. Do you get rashes? Does she have big bags under her eyes? Does she have a geographic tongue? Allergies any time of the year, and then it might be worth sending her for an allergy workup, But if she has no other allergic symptoms, that might be overkill at this point.
Or even just starting with that Region 17 panel, because I live in Oregon.
You could. If she has any signs of allergy, you could. But so far from what you're telling me, it sounds like she's got mostly gut symptoms and type 1 diabetes.
She has type 1 diabetes. She has GI symptoms. Yeah. She's got fatigue.
So chronic fatigue has also been linked to an allergic predisposition. So
I totally
it could be worth looking into allergy testing, Okay. So overall, from this article, I'm just backing up here. So overall, we have this sort of subgroup of patients with atopic bowel that we want to consider figuring out if they have food sensitivities, ideally via elimination challenge diet, and if they have inhalant allergies via either IgE testing or referring them to an allergist for skin prick testing. And then what do we want to do? So we talked about potential therapies. Of course, we can use all of our mast cell allergy interventions. Yep. We can do avoidance strategies. We can do environmental controls, which isn't part of the treatment section that we're going to do in a couple episodes.
Do you ever do a low histamine diet?
I cautiously do it because I don't want
to follow.
Because people are backing themselves into this corner.
Yeah.
And what I like to do is tell them, like, ideally give me a 1 or 2 day diet history, and we'll do some simple swaps. Like, instead of bananas, eat blueberries. Instead of spinach, eat kale. Yep. Let's not just take things out. Don't do bone broth, do meat broth. Those are probably my 3 top strategies for foods. So that's what I like to do instead of removing, is just switching it up. And then we're going to have a whole treatment episode, so I don't want to spend too much time on that, but we did talk about allergy shots, mast cell medications, and then I have another article or two that I wanted to very briefly touch on in this same realm of, like, inhalant allergens and atopic bowel. And so we don't know, is there like an underlying factor that's causing both of them? Does one sort of lead to the other? Is it all from intestinal permeability? We don't have an exact answer to that, but this other article looked more at how, like, actual sensitization to inhalant allergens may be an underlying trigger for both atopic disease and IBS. And we talked about that. So one potential theory is that inhalant sensitization is causing both phenomenon. There's other potential theories. There might be a genetic predisposition to both, which we're going to get to.
Wait, let me back up before you jump to that one. So let me repeat what you just said. You said inhalant allergies might be causing both the atopy and the IBS-like presentation of symptoms.
That's one possible theory, because we talked about this whole, like, inhalation of allergens. So that's one possible reason, right? The other could be that they've got intestinal permeability for other reasons that leads to both. The other could be, I'm going to get to in this last article. So this one looked at other ways that these two pathologies can interact. And so the two things I wanted to point out, this was interesting. So they did an experimental animal study that showed eosinophilic esophagitis could be induced by intranasal instillation of dust mite, aspergillus, and cockroach. And so inhalant allergies in an animal study caused a severe...
animals? It was an animal study, you
It
said?
was an animal study.
Were
Don't
they-
ask too many questions.
But did they
but
already have a known allergy to that thing? Or was it just random animals?
I believe it was random animals. Like, I think, so you can sensitize animals to inhale an allergens.
Yeah.
And so,
And these
too many
were
questions again.
sensitized?
Too many questions.
Okay, because I'm just wondering.
I have to
this-
look. I know. Are they already sensitized? I
Yeah.
don't think they were because, okay, so they might have sensitized them and then introduced a challenge where they then saw the EOE develop.
Yep.
Is probably most likely from now that I'm thinking about
Yeah.
it. Because you're right. If it was the first installation,
Right.
I doubt it would cause EOE right away. But I thought that was super interesting given the number of people we're seeing with EOE.
Right.
I mean, yeah, I am
Totally.
seeing a lot more people with
So
EOE.
there could be inhalation allergy with EOE as
We
part of
might
the
need to do
pathology.
an EOE
we
episode.
should.
We do.
Yeah, we should.
Yeah.
Yeah. It is interesting.
The other one that I found very interesting example they gave in this one study is patients allergic to birch pollen. Exposure led to local duodenal inflammation with increased eosinophils and IgE carrying mast cells. So just inhaling birch pollen got inflammation.
So basically, I mean, just to a
Yeah.
little bit recap what you just did.
yeah.
What you just did is you took my normal algorithm that I have
Yep,
been practicing.
you've gotta switch it up.
Yeah, damn you, dude. I don't like my brain is not flexible
I
like
know.
it used
I
to.
can't keep up. It's too much.
I mean, it feels like that a little bit. Like now I have to think about all of the infectious causes, all of the
Right.
autoimmune causes,
Right.
all of the dietary causes, and now I have to think about inhaled allergies.
Okay,
I
but at
quit.
least with inhalants, it's a relatively straightforward workup. Get the IgE
That's true.
panel.
Send
okay,
them to the panel. Okay.
If the panel's negative, send them to the allergist. If the panel's positive and they want to do sublingual immunotherapy or allergy shots, get them in with someone who can do that.
yeah.
So it's a relatively straightforward path, but it's then 3 to 5 years of therapy, which I think is very worthwhile for people with chronic
Yeah,
symptoms.
yeah,
We just have
totally.
to get out of like our fast food mindset of like I need a pill now. It's a long-term therapy,
talking
80%
about pills,
efficacy.
Do antihistamines work?
Okay, that's the treatment section, Alana. We've
not
got
to
an
that
episode.
episode yet.
guys.
We're not at that episode
See, now,
yet.
now
Pull
you're
your
like,
jets.
I mean, like,
This is the last part for today. So I want to go over the last few theories of what is the underlying cause of both atopic disease and IBS. We know there's some sort of immune dysregulation. So one other possibility that we sort of talked about is sort of some sort of mast cell dysregulation that's occurred that's, again, leading to both IBS and atopic disease. The other one, there could be, this I found very interesting, a genetic link to disruption of the tight junction barrier.
Oh.
genetically.
Yes. They were specifically talking about in the bronchial biopsies and intestinal mucosa. I don't think it's been proven. This is like a theory, but I thought that was pretty interesting. And then differences in gene expressions of how tight junctions are formed. So kind of along the same lines, but anyway, so there could be this. I often like downplay genetics because we can't do anything about it, but it could be interesting to understand that as far as like explaining to a patient.
And what I hear when you say that is there is some kind of like gene that we're going to look when we do their genomics that's going to be like the A12468 gene where they're like
Well,
just
maybe
more
there'll
atopic.
be like a shot that we can give people to correct the
CRISPR.
gene expression.
I mean,
I don't
would
understand
say
all that stuff, but-
Families do have allergies.
Obviously,
Yes.
allergies
You know?
run in families. Great
Yeah.
point, Rebecca. So we know there's genetic links to allergies. IBS, I don't know that I fully thought of that.
I
like
will
in
tell
my,
you, I usually think of it like, oh, the mom had a whacked microbiome,
Sure.
delivered the child. So I think about it from that perspective. But yes,
Not
the
a
mom
genetic
also
change in the
gave
tight
the
junction.
child
Yeah.
her genome.
Okay, so
At least
just
half of it.
overall, so we just went through a bunch of studies that showed sort of like this potential link between atopic disease and IBS, and we went through a bunch of theories on why that might be. And then if you want to do any conclusions of like,
Do you want to
overall?
I think we should recap.
Yeah.
Recap is good. I think in general, the workup you just outlined on how to do it, what we can do in office with people, that blood test, and then using our local allergists to test people.
Make friends.
Yeah, and obviously do an intake.
one of them.
Like on your intake, ask allergy questions.
Yep. Definitely.
I think that's super important.
Yeah. And then I think my take home was
this is yet another cause of chronic GI issues.
Unfortunately, yes.
Unfortunately,
but
yes.
It is correctable, unlike some other
After
causes.
3 to 5 years with injections on a weekly basis.
Or
Yes,
other
absolutely.
treatments.
Or
we'll get to.
sublingual immunotherapy works for some. They can do it at home, but still.
But we're
3 to
not
5
allowed
years.
to talk about treatments because you're not going to discuss any of them on
We'll
this
talk
episode.
about it next
Yet
time.
another Turd Nerds cliffhanger.
Dot. Thanks, everybody.
Thanks for
We'll see
tuning
you next
in.
time.
If you like this episode, please subscribe and don't forget to rate and review us to help spread the Turd Nerd word.
Thanks for joining us today. Stay tuned. We release episodes every 2 weeks.